Uh, Good evening, ladies and gentlemen. Welcome once again to yet another fantastic academic session hosted by ISA Thrissur City branch. Today, we are talking about perioperative fluids, and that is something which is very fascinating to each and every anesthesiologist. Protocols keep on changing from time to time, and every time we learn something new in every session on perioperative fluids. And now today we have an excellent speaker, Dr. Shalini Saxena, who's the director of onco-anesthesiology and onco-pain management at the Nanavati Cancer Institute and the Nanavati Hospital, Mumbai. Madam, welcome to Thrissur. It is a privilege having you here as a speaker. As you know, Thrissur, ISA Thrissur City branch has been judged as the best branch in the state and also the second best branch in the national level. We are regular in our academics as well as other co-curricular activities. And it is a pleasure to have you here today evening. So I also welcome our overseas participants, our state leaders, and other office members of ISA, and all our regular participants on all our academic meetings. So welcome once again, and over to you, Arun, for the proceedings. Thank you.
We will directly go to topic, madam. Without wasting any time, we can directly go to topic, and we will have discussions on proceedings after. So, welcome, Dr. Shalini, madam.
Start?
Yeah.
Yeah, so good evening, all friends and colleagues from Thrissur and overseas. And it's my pleasure to speak to you all. And I hope you will participate later with questions, and it should be a nice, lively session. And I also wish to thank the organizers from MedPiper and JournoMed, and Dr. Arun and Dr. Nivin and everyone. Okay, so so the topic today is perioperative fluids. How much, and whether this how much is not too much. So the aims of perioperative fluid therapy is to maintain euvolumia and oxygen delivery, and we need to avoid salt and water excess. Now, why this has become such a hot topic is because in 1999, the National Confidential Inquiry into Perioperative Deaths said that the errors in fluid management, usually hypervolemia, is the most common cause of perioperative morbidity and mortality. So IV fluids are a double-edged sword, and out of 300 million surgeries worldwide, 10% are very high-risk surgeries, out of which these 10%, there's 80% mortality, and the causes could be fluid-related, could be pulmonary edema, could be AKI, which has pushed the patient because of fluids towards morbidity and mortality. So what has changed over the years? Since the 19th century, when the cholera victims were given IV fluids and they were treated with that, there are a lot of things which have changed. Some physiological aspects have changed. The liberal algorithm has changed to goal-directed, individualized strategies. Fluid responsiveness and its prediction is become better with the cardiac output monitors. Choice of fluids we have got a lot of choices now. And of course, now we are also talking about procedure-specific fluid management. We are doing sicker patients. Now, if you do a robotic surgery, especially a robotic, say, prostatectomy, where you're giving a steep Trendelenburg position, you need to give less fluids. In thoracic patients, you're giving less fluids, liver resections, etc. During the dissection of the tumor, fluids are kept at a minimum. And in major cytoreductive surgeries with HIPEC, etc., you have to give a lot of fluids. So I will just touch upon each of these points one by one. So let's come to the boring one, that is the physiology. So let's talk about the third space. Now, for many, many years, we have been believing that there's a third space loss which happens when surgery is going on. Surgical trauma leads to a shift of the extracellular fluid into a non-anatomical third space. And we've all been giving fluids depending on the surgery to counter this third space loss. So in superficial procedures, maybe about 1 to 2 ml per kg per hour. And for a major abdominal surgery, it could be as high as 8 to 15 ml per kg per hour. And that was the fluid that we always calculated to give for the third space loss. But the third space does not exist. Studies have shown that the measurement of the extracellular fluid is flawed. The entire concept of a loss to the third space should therefore be abandoned. And it has been shown that when an organ like colon, like in a colectomy, is being manipulated, it weighs about 3 kilos. But the water accumulation that results is only about 150 to 300 ml. So initially we used to give more than a liter, 2 liters for this third space, but actually it doesn't happen. But during long procedures, inflammation-related redistribution of fluid does occur. It generally manifests in the postoperative phase, but may become clinically apparent intraoperatively because if the surgery is very long. Then we come to perioperative fluid administration. We feel that fasting causes hypovolemia, so we need to replace, but it generally, we are all practicing intermittent fasting and we don't get hypovolemic if we don't eat. Then, of course, in major abdominal procedures, there's bowel preparation. There's a weight loss of about 1.5 to 1.7 kg with water and potassium loss. Now, with the ERAS protocols, they say mechanical bowel preparation is no longer a standard recommendation. But our surgeons do give osmotic diuretics like Pegilec for bowel preparation. And so all these patients are either encouraged to drink fluids or they are given an IV fluid like a ringalactate at about 50 ml per hour overnight if bowel preparation has been used. Now, evaporative loss from the mucosal surfaces is difficult to estimate, but it is just about 0.5 ml per kg per hour. Water loss from respiration is also about 0.2 ml per kg per hour. The insensible respiration is another 0.5 ml per kg per hour. So all these losses just about amount to 1 to 1.5 ml per kg per day, which is about 600 to 800 ml. So we need to replace only about half a liter or just about a liter for these losses. We now come to the revised Starling equation. So we all know that the original Starling equation said that there are two pressures which govern the movement of fluids across the venous and the arterial end of the capillaries. So at the arterial end of the capillaries, the hydrostatic pressure pushes the fluid out, and at the venous end of the capillaries, the colloid oncotic pressure takes the fluid in. So at when Starling had made this equation, he said that the 90% of the fluid which is in the interstitial fluid comes back into the venules, and only 10% is returned to the venous system through the lymphatics. But the revised Starling equation says that the fluid which has gone out from the arterioles is all absorbed into the venous system through the lymphatic system. Lymphatic system gets back all the venous return. The fluid is not returned back at the venous end of the capillaries. Now, but what about the colloid oncotic pressure? This pressure is required because otherwise, if the colloid oncotic pressure goes down, then the fluid will keep leaking into the interstitial spaces. Then we come to the endothelial glycocalyx. Glycocalyx is present in the luminal side of all healthy vessels. This is a two-layer thing. One is the glycocalyx itself, and then is the one layer of the endothelial cells. So these two limit the vascular wall permeability. In health, the crystalloids are able to move either way along this layer. But when there is hypervolemia, if you've given a lot of fluids, there are release of cardiac natriuretic peptides, which degrades the endothelial glycocalyx, and it sheds and looks something like this. When there is systemic inflammation, again the endothelial cells also there's dysfunction. The capillary leak syndrome starts. Water, electrolytes, proteins, everything leaks into the interstitial space, maybe in the lungs, bowel, and connective tissue. Now, if the plasma oncotic pressure is less, it again facilitates the capillary fluid going into the extracellular space and consequent hypovolemia. And here both crystalloids and colloids will not be able to help in resuscitation. So let's look at it pictorially. So this is the intact glycocalyx. This is the second layer, which is the endothelial cell, and this is the intercellular junction. So if the intercellular junction is also, here the glycocalyx is destroyed, but the intercellular junction is intact, so the molecules are really not able to pass. In this part of the picture, the intercellular junction is also destroyed, the glycocalyx is also destroyed, and the fluids, albumin, everything will keep passing both ways. So what happens is that naturally occurring albumin has got positive and negative molecular surface charges, and this is able to maintain and actively contribute to the endothelial glycocalyx. But artificial colloid solutions have negative charges on their surfaces, and they are unable to the glycocalyx and thus unable to contribute to its integrity. So this is just another pictorial representation of the same thing. Here the glycocalyx as well the cell layer is intact. Here the glycocalyx is intact, but the cell layer is not intact, and the movement of the proteins and the colloids. Here there's no glycocalyx, there is movement, and here also the intercellular junction and the cell itself are not working, so the colloids and proteins can leak. To protect the glycocalyx, inhalational agents, sevoflurane is supposed to be protective towards it. And of course, steroids and antithrombin 3 and antioxidants. Ischemia, sepsis, inflammation, hypervolemia, natriuretic peptides, hyperglycemia, stress, all destroy the glycocalyx. And it takes about 5 to 7 days to regenerate. Now this other concept of hypovolemia has also come. We are talking about the mean, here this is independent from the mean arterial pressure. It is how hypovolemia is related to cardiac output maintenance. So the whole venous capacity, all the blood in the venous system in the body is divided into two volumes, the stressed and the unstressed. The unstressed volume is about 70%. The stressed volume, which contributes for venous return, is about 30%. The unstressed volume is the volume which is in the splanchnic circulation. Here the veins are the capacitance valveless veins. It's something like the functional residual capacity, if that analogy can be taken. So now this is a tub where the spout of the tub, the outlet of the tub is not at the bottom, but it is somewhere in the middle. So when the venous return has to go to the heart, the stressed volume contributes to it. And there are two pressures which contribute to this, is the mean systemic filling pressure and the right atrial pressure. So then the venous return comes to the heart. Now, if there is vasodilatation, what happens is that the stressed volume and everything increases. The unstressed volume also increases. The systemic filling pressure as well as the right atrial pressure will decrease, and the cardiac output will go down. So the same thing is represented when there is absolute hypovolemia in an hemorrhage kind of situation. So both the stressed and unstressed volumes go down. In vasodilatation also the volumes go down because the capacity of the venous bed has increased, and here you may have to give volume as well as vasopressors to maintain the cardiac output. And here it has been shown that if initially when there is compensated hypovolemia, the unstressed volume goes down to maintain the cardiac output. But if it is uncompensated, the volumes go down, still the cardiac output is not maintained. And in a relative hypovolemia also, the same thing happens, that the cardiac output is not maintained. So what we must do is try to maintain the cardiac output. So every time the fluids may not be required, you may require vasopressors. So when we look at fluid responsive, again, we come to the Frank-Starling law. Everyone is aware of this law, that when there is stretch on the cardiac muscle, the contractility will increase and the stroke volume goes up. So as you increase the preload, the contraction happens and stroke volume goes up. Now, if the patient is in the initial part of this curve, at that point in time, the patient will be preload dependent. And if you give a fluid bolus, then the stroke volume goes up. If the patient is on the flatter part of the curve, that means patient is already his preload independent, more volume will not increase the contractility. So this is the curve in normal patients. And if the ventricular function is depressed, then this curve goes down and the patient will not tolerate volumes at any point of the curve. At this point of the curve, he may tolerate some volume, but not when he is in the flatter part of the curve. So that finishes physiology, and poison is in everything, and we need to give the right doses. So something about composition of the IV fluids. Now, we all have come to know that normal saline is bad, and it can cause severe hyperchloremic acidosis. So the osmolality is little more than that of plasma, and the sodium as well as chloride content is more. Now, when we come to balanced crystalloid solutions like Ringer's, plasma like, stereofundin, etc., they are slightly, Ringer's hypotonic, the plasma light and stereofundin are isotonic with reference to the plasma, and their sodium content is similar to that of the plasma. The chloride content is also similar to that of the plasma, and they have got a buffer solution. Now, either it is a lactate buffer, plasma light has got a buffer which is both gluconate and acetate, and stereofundin has got an acetate buffer. So let us see why these buffers are important. The next concept that I wanted to talk about is the strong ion difference, which is the difference between the negatively and positively charged ions in the plasma. So sodium, potassium, calcium, magnesium are the positively charged, and the negatives are the chloride, lactate, and bicarbs. So physiological solutions will require a strong ion difference of about 40 to 40 milliequivalents, so as to not produce any acidosis or alkalosis in the neutral pH. So what happens if you're going to give 1 liter of saline is added to the plasma? Now, the strong ion difference of the normal plasma is around 38 to 40. When you add saline, 1 liter of saline to the plasma, because of the chloride, there's more acidosis, and the strong ion difference becomes around 19. So it will cause a hyperchloremia, will cause acidosis. If you give 1 liter of Ringer to this patient, what will happen is that Ringer has got a lactate buffer. So from 38, because this lactate gets metabolized immediately, the strong ion difference will not change and patient will not get acidotic. There are two unanswered questions that when crystalloids are given to awake patients, 75 to 90% of it is excreted in the 2-hour period. But under GA, only 5 to 10% of the fluid gets excreted. So under GA, all this fluid is retained in the interstitial space after 20 to 30 minutes. But why this difference between an awake and anesthetized state? The answer has not been. There is not much. It's like it's a controversial topic. and why the fluid accumulated intraop in the interstitium is not readily excreted after surgery, while that which is administered post-op is promptly eliminated. So in awake volunteers, the half-life of the crystalloids may be anywhere between 23 to around 70 minutes. In dehydrated volunteers, it's about 76 minutes. But when intraoperatively, the same, if bringalactate, which is given around 25 ml per kg over 30 minutes, it takes about 300 minutes to get excreted out. And the same fluid, if it is given post-op, like in a laparoscopy patient, it takes about 17 minutes. So there is a difference between the excretion of fluid in an awake and a GA in a general anesthesia state. So let's go to the perioperative period now. We finished with the physiology. So why do we give fluids? As I said, we feel that if the patient is fasting, he is hypovolemic in the pre-op period. Plus, there's release of hormones like antidiuretic hormone, which is released because of stress and fasting. And this hormone causes water and sodium retention. And the hormonal milieu continues to be antidiuretic during surgery. Of course, bowel preparation we've already talked about. That also results in dehydration and potassium loss. And the patient may be having some obstructive disorders or pancreatitis, etc., which are already, there may be pre-existing inflammation and interstitial edema. Now, in there are surgery-related causes which cause hypovolemia: blood loss, evaporation, third spacing, which we know that does not exist anymore. Plus, there may be leak of albumin caused by inflammatory mediators, decreased venous return, compression of the IVC. There could be coagulopathy due to hemodilution. With laparoscopy, abdominal insufflation causes the splanchnic circulation to push fluid, or if the great vessels are compressed, then the venous return goes down. Prolonged operative time, urine output may become less. And of course, anesthesia may be related both to general and regional anesthesia. Anesthetic agents cause dose-dependent vasodilatation, myocardial depression, hypotension. Spinal anesthesia, we all know, causes sympathetic blockade, and the patient, BV falls and we feel patient is hypovolemic. Positive pressure ventilation with high tidal volumes, high PEEP, and recruitment may also result in hypovolemia. So that's the reason why we give fluids. So how much fluid is just right? Now, this is an inverted umbrella where the middle part is the optimal state of fluid balance. On either side is over or under hydration, and both are bad for the patient. So if you underhydrate your patients, then there is poor perfusion of the organs, poor oxygenation, bowel ischemia. The cardiac output is less, tissue perfusion, shock, everything, tissue perfusion decreases, shock happens, multi-system organ failure will happen. Bowel ischemia can cause anastomotic leaks. If you overhydrate your patient, again, there is bowel edema, poor perfusion, poor oxygenation. There may be pulmonary edema, pneumonia, GI edema, decreased motility, ileus. Anastomotic leaks can also happen with overperfusion. Dilutional coagulopathy, wound healing is also impaired. So we need to see that our patient is in this base of this umbrella. And in a normal patient, this is a wider curve, but in diseased patients, cardiac patients, there's a very low safety of giving fluids. So approaches to intraoperative fluid therapy have changed over the years because of awareness of the consequences of hypervolemia. And the modern perioperative practice has moved from older traditional therapies to being more restrictive. So the terminology which is used is fixed volume, goal-directed or individualized therapy, restrictive, liberal. So some of these terms are vague and ill-defined. So what do you mean by a liberal therapy? Liberal is more than about 3 liters per day. It is based on an algorithm. We'll see it a little later. Plus third phase losses. And what happens if you give liberal fluids is you damage the vascular endothelial glycocalyx. There is a weight gain of 3 to 6 kilos, bowel edema, as I already told you, delay in wound healing, increased length of stay in the hospital. But if you give 1 to 2 liters of fluid to day care patients for minor procedures, it is supposed to reduce post-op nausea, vomiting, and in turn, this will reduce the post-operative pain. Now, restrictive and zero balance are two terms. So where they can be used interchangeably, but zero balance means that there is absolutely no weight gain in the post-op period. In restrictive, it means that the patient can gain about a kilo of weight in the post-op period. In both these restrictive and zero balance infusions, what happens is you don't cover for the pre-op period. You don't preload the patient if you're giving spinal. You avoid the replacement of non-anatomical, the third space losses, etc. And if the patient is hypotensive, you give fluids accordingly, give fluid boluses, blood loss is replaced, electrolytes are replaced accordingly. So in the zero balance means there's only a background infusion going on, and the fluid is replaced as per need, and there should be no post-op weight gain. We have over the years in certain surgeries, we are giving more than 5 to 6 liters of fluids for major surgical procedures, and patients gain about 5 kg of weight. So this is just this study was done by Chappell in 2008, where if you have given about 10 liters of fluid, if you have given about 5 to 10 liters of fluid, the weight gain is 5 to 10 kg. We come to the standard management, which we always followed with respect to fluid therapy, the maintenance of 4:2:1 rule, where the deficit was calculated into hours of fasting, third space losses was calculated, and also the blood loss was added. The replacement by crystalloids was in the ratio of 3:1. So this is an example of an 80 kg male patient who's for an APR surgery. NBM of 8 hours, 6 hours surgery, estimate blood loss about 1,500 ml. So by using this maintenance formula, the patient would receive about 12 liters of crystalloids intra-op. And in the first 3 hours itself, these insensible and third space losses would give him about 2 liters of fluid. And in 3 hours only, you give about 5 liters of fluid. So obviously this is bad, as has been studied. I will talk to it about it subsequently. And there is also this thing on guesswork, how good we are at guessing how much fluid a patient requires as anesthetists. So they 5,000 patients were studied for intra-abdominal procedures, and there were no guidelines on the fluid administration. So different procedures, prostate, pancreatectomy, hysterectomies, colectomies, nephrectomies, everything was studied, and there was a wide variation in the amount of fluids being given. The range was 4 to 10 ml per kg per hour, and the strongest predictor for the amount of crystalloid was the anesthesiologist, who would guess and decide, okay, now this patient needs fluid, I will give him more or less. So post-op fluid overload is not a benign problem. It is associated with more the fluid balance, worse the outcome, and a weight gain of more than 20% has resulted in 100% mortality. And this study was done as early as 1990 by Lowell. Then came Dr. Brandstrup, who has studied the fluid, who has studied fluids and a lot of papers on this. The most important paper of hers was in Annals of Surgery in 2003, where restrictive fluid therapy was first recommended, and here the postoperative complications reduced by 45%. So there were two groups in which she had, and the restrictive group was just about 3 liters. In the liberal group, more than 5 liters of fluid was given, and she found that if the weight gain and they gave furosemide to treat the weight gain, and colloids were used to replace the blood loss. Preloading, replacement of third space, and urine output was all third space and preloading was eliminated. Urine output was calculated and fluid given accordingly. So here there was a 45% reduction in the complications. Again, she did a study in 2012, but here there were not too much of difference, because these patients were again zero weight gain versus goal directed. So the amount of fluids was given was less in both the groups, and the complication rates were identical. The second graph is of this same 2003 study, where if the more weight gain resulted in more complications. So restrictive volume strategy has been also, there's a meta-analysis done in 2012, where they have studied 23 RCTs with goal-directed therapy and 12 RCTs with liberal fluid therapy, about 4,000 patients, about 1160 patients, and the liberal group had a higher risk of pneumonia, pulmonary edema, and a longer length of stay. So from early 2000, because of ERAS and this goal-directed, the restrictive volume strategies have come into play. So in ERAS, what happens? That the patient, it is a continuum of care from the pre, intra, and post-op periods. In ERAS, it is advocated the patients need not fast for 8 hours. They can drink fluids up till 2 hours before the surgery. And so the patients are not very hypovolemic. There is no mechanical bowel preparation advocated. So no water and sodium and potassium loss. And carbohydrate drinks are given to counteract the catabolism of fasting. Carbo load is available, and so is API. API is cheaper than this and can be given in the night and morning before surgery. So what happens is, if the patient has had clear fluids, is that it improves the metabolism, decreases the insulin resistance, reduces anxiety, and also post-op nausea, vomiting. With ERAS protocols coming in, laparoscopic and minimally invasive surgery has also become popular, which reduces the physiological derangement and insensible losses. Correction of anemia is done in the pre-op period. It improves the tissue oxygenation. And but epidural has been advocated as a part of ERAS, and that may cause hypotension, which needs to be taken care of. So fluid requirements in ERAS versus the traditional preoperative care are different. Now, by the ERAS pathway, if you see this, the fluid in the pre-op, the surgery, and the post-op period, including the post-op day 1 and 2, remains in this green zone. So there is only a weight gain of maybe a kilo or so. And in the traditional pathway, what happens is the patient is fasting. So the patient is negative, then you're giving a lot of fluids, and they may continue to be more in the post-op period. So if you keep fluid therapy to a minimum and not use urine output as a driving force, then the AKI, pulmonary complications, everything is reduced. There's reduction in the length of stay and of course the costs. So ERAS pathway is also advocates that the fluid should be restricted. Now we come to monitoring of the volume state of the patient. So the focus is on pressure. We always feel, oh, the patient is hypertensive, we need to give fluids. But organs require both pressure and flow. And intraoperative fluids enhance the flow. Actually, they increase the flow, the venous return goes up, and then the cardiac output increases. So how do we check? We are monitoring static parameters, the blood pressure, heart rate, CVP, urine output, and mixed venous oxygen concentration. The dynamic parameters, which have now recently become very popular, are the pulse pressure variation, systolic pressure variation, the stroke volume variation, and plethysmograph variation index. And TEE and other non-invasive technologies like bioimpedance, reactants, etc. So we will just look at first the static parameters. So NIBP, and that is the blood pressure and heart rate, are unpredictable, because if your patient is in a light plane of anesthesia, or because of the surgical stress itself, subclinical hypovolemic state may still show a normal BP and heart rate. And of course, if you have given spinal, or if the patient is on beta blockers, again, there is no increase in heart rate if the patient is hypovolemic. CVP and pulmonary artery pressures are also inaccurate to determine the preload, and they are poor predictors of fluid responsiveness. And it will not tell you that the patient is now going to develop pulmonary edema. Urine output 0.5 ml per kg. It is an indicator of hypovolemia, but inhalational agents and surgical stress can also reduce urine output. Mixed venous oxygen saturation for oxygen delivery has limited utility to guide fluid therapy. Passive leg raising transiently increases the venous return in patients by about 300 to 500 ml, but it cannot be used intra-op. Avoidance of hypotension is also important because hypotension can predispose a patient to postoperative myocardial injury and kidney injury. They were all strongly associated with mean arterial pressures of below 65 millimeters of mercury. This was a cohort analysis of 57,000 patients. Of course, so a lot of data cannot be extrapolated, but this is what they found. And if the mean arterial pressure was more than 50% below the pre-op values, even for 5 minutes, it increases the risk of myocardial and kidney injury. Now, mean arterial pressures are different in different patients. Now, in hypertensive patients, you may have to keep a mean arterial pressure of say 75 and things like that. So it was not a very good guide. Again, CVP and blood volumes. Now, blood volume, even if it reduces and if it increases, CVP is all over the place. So there is no association between hypotension and hypovolemia and CVP. A little more about urine output. Reduced intra-op urine output is neither a trigger nor a predictor of acute kidney injury. If you lose blood, if there is hemorrhage, then the urine output falls. But if the urine output gets established at the end of resuscitation, it doesn't mean that the patient will not get kidney injury. And established urine flow is not a tool to define the end of resuscitation. Administration of crystalloids may cause multi-organ failure. And you keep giving crystalloids so that the urine output increases, but urine output may increase, but abdominal compartment syndrome can also happen. Come to dynamic monitoring. So we saw that the heart rate, BP, CVP are all single point snapshots. They don't tell you a trend. So the dynamic indicators have come as predictors of fluid responsiveness. That could be variation in the systolic pressure. This variation happens with every respiratory cycle. It can be calculated, and with that you come to know pulse pressure variation with the arterial BP, the systolic blood pressure variation, the stroke volume, and plethysmographic variation. So normal respiratory variations are less than 10%, and if these variations are more than 14-15%, then you can give fluids to the patient. Now, normally we are giving low tidal volumes. So there was this Indian study by Dr. Mehatra and all, where they gave in the low volume tidal volume strategy, they transiently increased the tidal volume and checked for fluid responsiveness because these variations on the pulse pressure increased. So if the variations increase, then you know that your patient is going to be fluid responsive. These dynamic parameters are unreliable in spontaneously breathing patients with a high respiratory rate, open chest injury. If you're giving low tidal volumes, a high PEEP in during laparoscopic arrhythmias and RV failure, because in arrhythmias also you will not get a proper tracing of your arterial BP. So methods available to detect fluid responsiveness, again by observation. Now when we detect a lot of variation with respiration, we know okay, this patient will be fluid responsive. Passive leg raising, I've already told you, tidal volume challenge, recruitment maneuver, and end expiratory occlusion test. When you do a kind of a Valsalva maneuver, then suddenly the BP etc. fall. And of course, a fluid challenge of about 250 ml. If it increases the stroke volume, then you know that the patient is fluid responsive. A study was done that how of the ability of the anesthesia providers to visually estimate systolic pressure variability using the eyeball technique. So we all see this in the operation theater, and the anesthetists were asked to examine these readings and estimate the systolic pressure variation as a percentage. And then they were told whether to ask whether they would administer fluids or not. So the anesthesiologist responded that the fluid administration was appropriate if the systolic pressure variation was more than 14.5%, and the eyeball estimates were within clinical limits in 82% of the cases, and the physician's decision to administer fluids was incorrect. That is, they were correct more than 95% of the time. So this eyeballing technique is a technique I think we all follow in the operation theater, and it is working. Coming to goal-directed hemodynamic therapy, it is an individualized fluid therapy that adapts to changing patient needs during the periop period. The goal is to maximize oxygen delivery and with minimal oxygen consumption. The optimal goal is yet to be sometimes to be determined. What are you going to what do you want for your particular patient? But stroke volume is the most commonly used parameter, which is considered for giving either fluid boluses or vasopressors. And the gold standard was the pulmonary artery catheter, but now semi-invasive and non-invasive devices have come: esophageal Doppler, the flow track and Acumen Litco, tissue oxygenation parameters, and bioimpedance and bioreactance, which are non-invasive. So the arterial waveform tracing gives you pulse pressure variation, and if the variation is more than 10 to 15%, the patient is fluid responsive. If it is less, you stop fluid administration to avoid hypervolemia, and if your BP is not maintaining, you may have to start vasopressors. Esophageal Doppler has also been used to estimate the stroke volume. Transesophageal echocardiography estimates the left ventricular cavity size and the IVC collapsibility. Non-invasive technology, which depend on the pulse oximeter, pulse contour analysis, CO2 rebreathing, thoracic electrical bioimpedance and reactance, are also other platforms. So this is just a picture of the monitor for stroke volume. This is the bioreactance, and this is the Acumen monitor, which we had an opportunity to use it for a few cases, which tells you the hypotension prediction index. So if it is 90, then you know that your mean arterial pressure is low, and you may have to do something about it. If it is 50, that means the patient will not have hypertension. And of course, in addition, it gives you the stroke volume, the variation, the SVR, and the cardiac output, everything. So we need to identify which physiological parameter we are going to monitor, and whether it is going to be associated with improving our patient's outcomes. So this is an algorithm which is used during a goal-directed therapy, that if post-induction you do your stroke volume assessment, you may give a 250 ml fluid bolus. If the stroke volume increases by 10%, fine. If it does not increase, then is the patient at the target stroke volume? If it is less than a decrease of 10%, then again you can give another bolus. If not, and if the mean arterial pressure is less than 65, then you need to start a vasopressor. So this is how the goal-directed therapy works with giving fluid boluses and vasopressors. So major systematic review on goal-directed therapy to improving outcomes. So using an intervention, the mortality of up to 180 days was reduced as compared to the usual care. Another systematic review on preemptive hemodynamic intervention to improve post-operative outcomes was also done, which favors the goal-directed therapy when used preemptively to improve post-op outcomes in high-risk surgical patients. Microcirculation is also important. We are always doing, all the studies are for macro circulation. So there was this one study for testing the microcirculation by checking the sublingual and cutaneous microvascular flow and cutaneous tissue oxygen partial pressure. Of course, in this study, they also studied the inflammatory markers. The patients were divided into 3 groups. Fluid was given as per CVP, as per stroke volume, and as per stroke volume and dopexamine. So the conclusions were that the systemic variables were no different. There was acute kidney injury, 22% in the CVP group, and the microcirculation was reduced post-operatively in the CVP group. And this is the these are the patients who develop post-operative complications. So this is only one study which I found on microcirculation. Now about goal-directed fluid therapy, it has evolved from pulmonary artery catheter to stroke volume optimization. So it's become less invasive. So either you use stroke volume variation or esophageal Doppler, etc. is used. There are multiple studies on goal-directed fluid therapy which showing significant decreases in morbidity and mortality, especially in high-risk patients. And these outcomes have persisted even on long-term follow-up. We need to use early timely goal-directed therapy to decrease the cardiovascular events in high-risk patients. Now, more recent studies on goal-directed therapies have failed to show the same results. Because of multifactorial reasons, the trials are quite heterogeneous in their nature. 2 large studies, Optimize and POE-MAS, has shown no difference in mortality or post-op complication at 30 days. I think this may be because clinical practice has changed significantly over the years, and ERAS protocols also advocate less fluids. We are giving less fluids. So possibly the ERAS, etc., has attenuated the benefits of goal-directed therapy. So when we are doing high-risk cases, or for that matter, any patient. So if the patient's ASA risk is ASA 1 or 2, and the surgical risk is not too much, then there's no need for goal-directed therapy. If the surgical risk is high, as well as ASA 3 and 4 patients, we need to do goal-directed therapy and consider ICU, etc. If the surgical risk is not high, but the patient is ASA 3 or 4, then again, we need to do goal-directed therapy. The 5 T's of goal-directed are, again, you need to have a target population. The timing is very important. If the patient is high risk, then you may have to start it in the immediate immediate intra-op period. The type of intervention, vasopressor, fluid, or inotropes, and what variable you are targeting at. And you need to personalize the target values. Come to type of fluids. Just to make a mention that normal saline, as I told you, causes hyperchloremic acidosis, so it should be avoided. Use balanced electrolyte solutions. The synthetic colloids are controversial, and of course, blood and blood products are used as required. So there was a study in a British Journal of Anesthesia in 2018 where normal saline was compared to a balanced crystalloid for goal-directed therapy in major abdominal surgery. Now this study was terminated after 60 patients because the normal saline group developed hyperchloremic metabolic acidosis and they needed more vasopressors and for circulatory support. Therefore, another study showed that hyperchloremia after non-cardiac surgery is independently associated with increased morbidity and mortality. So we need to be very careful when we use normal saline. We should use balanced crystalloids. Now there is another controversy that how much crystalloid you should use to replace the blood loss. The initial was 1:3 ratio, but now this ratio has become 1:1.5. There are various studies where they have given double the amount of crystalloids. We were giving triple. Now we have to give only 1.5 times. When you consider crystalloid versus colloids, greater volumes of crystalloids are required to meet the same targets than the colloid. So if you're giving colloid, if there's a blood loss, then you can give colloid 1:1. And of course, this review says that isotonic crystalloid solutions, the balanced crystalloids, are better. Now we come to one or two outcome studies of hyper as well as of volume management, fluid management. Here in this 2018 meta-analysis, no, it's a retrospective cohort study with 92,000 patients where there were 5 groups from restrictive to liberal. The liberal group is also just about 3 liters of fluid. And the moderate group is about 1 to 1.5 liters of fluid. So what they found that the middle group, the mortality, the respiratory complications, kidney injury, length of stay, etc., everything is minimal in this in the middle group. Too high or too less is also bad. In the restrictive group, there was a very high incidence of post-op kidney injury. Then another study says about the same thing, which was of the volume derangement in colorectal hip and knee surgery, also has produced a similar. The group where the volume is high has higher incidence of complications with respect to length of stay and post-op ileus, and you have to be not too restrictive and not too liberal in the fluids. Another one association, there's a multi-center retrospective study where they said both higher and lower volumes can cause harm, and the middle group is the best. The complications being more than one complication in terms of infection, gastrointestinal, cardiovascular, renal, and respiratory. There is this one study which has said that if the patients were given more than 6 liters up to 9 liters of fluid in the first 48 hours of surgery, the mortality rate was 48% higher than expected. So there were in this study, there were 21% of patients who were given 6 liters of fluid and 2% of patients who were given 9 liters of fluid, and which has added to the mortality. So if there has to be a balance between the for the fluids that we need to give. So we should not cause a weight gain of more than 2.5 kilos. So what about too little? So this is this big trial by relief trial by Miles group, which said that if the fluids were less, then there was a higher chance of AKI, 8.6% versus 5% in 3,000 patients who were studied for abdominal surgery. So the patients after 1 year, there was no difference in the disability-free survival, but AKI was seen in these patients where restrictive fluids were used. So oliguria reversal in goal-directed does not mean that kidney dysfunction cannot occur, and less kidney dysfunction was seen in patients with goal-directed therapy without the use of oliguria. So, and another study showed that intraoperative urine output, if it was less than 0.3 ml per kg, was associated with higher risk of acute kidney injury. So intraoperative oliguria is associated with post-operative acute kidney injury. So you need to keep the urine output 0.5 ml per kg per hour. The positive predictive value of oliguria is just about 25%, but negative predictive value is 81%. So what do you do for renal protection? You need to put in a catheter, correct hypotension, avoid NSAIDs and angiotensin receptor blockers, and if the GFR is less, no colloids. And there should be protocols to maintain the fluids even post-operatively. We come to some specific procedure requirements, like we do a lot of liver dissections. So during liver dissections, it's important that when they are doing the initial part of there are two, 3 phases. So in the initial part, during resection, to minimize bleeding, you need to reduce the portal pressures, give reverse Trendelenburg position, give less fluids, low CVP, and use a high stroke volume variation. may have to give NTG to bring the CVP down, may use diuretics. So this is an algorithm where in the initial dissection phase, you need to keep the stroke volume variation high up to 20%. And later on, then you can give fluids and vasopressors depending on what the requirement is. Same is for pancreaticoduodenectomy. Here also, initially when the tumor is being removed in the extirpative phase, to prevent leaks in the pancreas and delayed gastric emptying, you should give less fluids, and later on fluids can be given during the reconstructive phase. It contributes to lower post-op pancreatic leaks and delayed gastric emptying. And there was this one study on the fluid administration in cytoreductive surgery with HIPEC, where they gave a restrictive 9 ml, less than 9 ml, non-restrictive 11 ml, greater than 9. So it was around 11 ml per kg, which they said that the restrictive group had higher complications. So in these cases, you need to give proper fluids. So to summarize, fluids are drugs and not easy to determine their needs. Both hypo and hypervolemia are bad. So we need to maintain euvolemia. We should see that our patients don't come dehydrated. And if you give hypervolemia can cause tissue edema. Static parameters like BP and urine output and heart rate may not recognize the decrease in tissue perfusion. So either use dynamic monitors or use your judgment by seeing the stroke, the pulse pressure variation. For balanced crystalloids, it's a grade 2C recommendation, and replace the blood loss with the crystalloids 1:1.5 or colloid 1:1 on a volume basis till the transfusion threshold is met. So for what do you do for minimally invasive procedures? With early ambulation, you can give little liberal fluids so that the patient doesn't have PONV. For major invasive surgical procedures, give a restrictive or a goal-directed therapy rather than traditional liberal fixed volume approach. And strategies should be based on blood loss. If the blood loss is going to be more, then and fluid shifts are going to be more, then use your pulse pressure variation or stroke systolic pressure variation in the arterial waveform tracing and determine the responsiveness to the fluid boluses. For high risk patients where the blood loss is going to be high, and then select a device and give fluids and vasopressors accordingly. The post-op period is also very important. The orders for fluid should be very specific, because sometimes when you're mobilizing patients, they can have postural hypertension if you're giving too restricted a volume, and then the patients can fall, etc. And avoid we can also modify our anesthetic technique. Don't give too deep an anesthesia, which will automatically reduce the BP and cause hypovolemia, reduce the venous return. So early optimization is very important in high-risk patients. We generally follow the reactive approach. Okay, the BP is fallen. Okay, give a shot of ephedrine or phenylephrine. But then you wait. Okay, for the patient not responding to boluses of your drugs. Then you start an noradrenaline infusion and things. But in high-risk patients, it is better to keep everything in place and with your proper monitoring and everything. And have your target of pulse pressure variation or stroke volume, and maintain the cardiac index and oxygen delivery. So it's very important in high-risk patients, because the outcomes will be better if we follow a proper proactive approach. It's like walking the tightrope. Both sides are bad for the patient. And of course, elective surgery is different from emergency surgery. So this is mainly for elective surgery, and major surgery is different from mild surgery. Now we have come from last 200 years of giving fluids, from a supranormal approach to restrictive to goal directed. The world is changing, and so are we. Thank you.
Thank you, madam, for the extensive. Certainly, we can.
Thank you, madam. It's a talk, very excellent talk, very prepared, and I'm sure that everybody would have gained something new from today's topic. Arun, would you like to manage the question and answer session, or will South
I'm sorry, I couldn't get the question. Your voice
no problem. Yes. Doctor, we have got few questions in the Q&A. So maybe if any medical term, if I'm wrongly pronouncing, kindly excuse, okay? So I'll start with the first question. Good evening, madam. If patient posted for emergency laparotomy for DUP or enteric perforation with septic shock, ABG facility not available in government hospital. Explain fluid therapy strategy.
So of course, there's a lot of fluid shift happened in an emergency case. So you need to replace the volumes in a setup where you don't have ABG and things. At least I think a CVP line in these cases is a must, and a urine catheter. So you have to with the CVP and urine output and the blood pressure, you need to do your fluids. And of course, depending on if it is a DU perforation, there's going to be potassium loss also. So either maybe you may have to replace. There is hypokalemic metabolic alkalosis, right? So you need to replace the potassium also. So now whether you're going to do it empirically, something has to be done, because otherwise your patient will not breathe post-op. I hope that answers your question. You need to give fluids. You have to during and of course when you when the patient is taken up for surgery and the abdomen is open, then that splinting effect goes. The patient may just crash. So you need to hydrate your patient very well in these cases.
Okay,
and replace potassium.
Okay, thank you, ma'am. Dr. Ganesh, are you online? Please unmute and ask directly.
Ma'am, I've been doing some debulking surgeries of CORE or CS stomach under thoracic epidural plus general anesthesia. And most of the patients have been given PEGLAC or something like that. Though they have been replaced with volume, the volume has been replaced. The moment you charge the epidural, the blood pressure crashes, and you really have to press in more fluids, or I should be starting the vasopressors.
Yes, so we are also facing this problem. So what we are doing is that for these long procedures of cytoreduction and things, which go on for 7 to 8 hours, most of the times we put in an arterial line. If you are doing a thoracic epidural, give a very low dose, like 0.0625% of bupivacaine or 0.1% of ropivacaine at a low dose. Sometimes we don't start the epidural infusion till after surgery. We start it only later. Maybe give a small dose of opioid. Even sometimes buprenorphine works, 100 or 150 mics of buprenorphine initially, and then give your local anesthetic infusion later. And take an arterial line. A very low dose noradrenaline is very good in these patients, so you don't have to give too much of fluids also, because sometimes you really the patients, the BP also doesn't come up, and you're giving fluids and nothing happens. So noradrenaline really works in these patients.
Okay, madam. Thank you.
And very, very low dose of epidural local anesthetic.
But these patients, when they are shifted postoperatively, the ICU registers also immediately discontinue the epidural post-op maintenance because the BP falls. So
the epidural is the first casualty. The epidural is the moment the BP is around 90 millimeters of mercury, the ICU will just shut off the epidural infusion. So what we do is it's a very low concentration of local anesthetics, and we tell them no, we will continue that, and you continue your noradrenaline.
Okay. Many of
It's
them
like
are
a SIRS. Pardon?
many of them are not comfortable with vasopressors when they are given done some resection analysis.
No, slowly our surgeons are accepting small doses of noradrenaline now.
Okay. Okay. Thank you so much.
Thank you. Dr. Jayadi, can you please unmute and ask the question? Dr. Jayadi Ghosh. So her question is, what about the 4-to-1 rule for intraoperative fluid? Is this still valid?
No, it is not valid because as I showed you that we are giving more than 9 to 10 liters of fluid, and this excess of fluids more than 5 to 6 liters for an 8 to 10 hour procedure is causing a lot of weight gain. Then the surgeons in the post-op period are giving furosemide, they're giving albumin to remove all that water. That water takes 4 to 5 days to come out. It's so much of positive balance. So we have stopped the 4:2:1 rule, and because the third space is the third space doesn't exist anymore. So we are not giving more than 5 to 7 ml per kg per hour, and just keeping it at that. And if required, giving small fluid boluses to maintain the BP and the urine output. We are also accepting, we don't want 100 ml of urine per hour for every patient. We are okay with about 30-40 ml per urine, and it should come constantly. So 4:2:1 we are not doing.
So question from Dr. Ashu Matai. Will the lactate measurement help in guide fluid requirement?
Yes, lactates do help, because if the patient has become very hypervolemic, and so the lactates, which are, initially if you run a blood gas, it's a 1.6, and then suddenly they become 3.8, etc. So they do, but they are not the whole and soul guide. The other stroke volume variation, I think, is a very good pulse pressure variation is very good. If you put an arterial line, you really come to know, that in all our latest monitors, when you can get an arterial BP, you can get your pulse pressure variation. If it is 8 to 10, don't give too much of fluids. If it is 14-15, give some fluids, give a bolus and see. Otherwise, start our threshold for starting noradrenaline has become very low. We are starting noradrenaline immediately. Even if you don't have a central line, a good peripheral vein, one ampule in, say, 100 ml of normal saline can be started as an infusion. It works very well. And lactate is a good guide, but it is not the only thing that we monitor.
Okay. Thank you, madam. Now, another question from Dr. Saumya. Which is the best predictor for fluid responsiveness in an ICU patient on ventilator?
In an ICU patient, I think if you have a arterial line, then it is pulse pressure variation only. That is quite good. Or you have to then otherwise get your ultrasound machine and do a point of care IVC collapsibility. That's the only thing. But that also IVC collapsibility is like there's so much of inter-operator variability and things. So at least pulse pressure variation is a value that you can get, and you can give a fluid challenge and see what happens.
Okay.
And in other than passive leg raising, which has been advocated so much, you can, if the tidal volume is say 6 ml per kg, increase it to 10 ml per kg and see if the variation increases, the pulse pressure variation. Then give a fluid bolus.
Okay.
So I think the IVC collapsibility and the pulse pressure variation, both should be used.
Okay. And the question from Dr. Chavarkar. Do we discontinue the practice of preloading fluids in LSCS to avoid hypotension after spinal?
I think preloading is now not given up. We are doing co-loading. And of course, I think our threshold for noradrenaline has reduced, our threshold for phenylephrine is also, instead of giving mephentermines and ephedrines, phenylephrine in labor OT has become very standard these days, I think.
Okay.
because we know the reason is sympathetic blockade. So it's not going to be fluids which are going to get that BP up.
Okay. And madam, we would like to know which balance salt solution you use in major surgeries like colorectal surgeries or and other surgeries. Do you use normal saline renal lactate or expensive stereofundin?
See, for most of the surgeries, colorectal, etc., we are using ringers. And if a surgery is a liver resection and hepatectomies and those kind of, then we are using plasma light or stereofundin.
Okay.
But normally we are using ringer lactate.
What's your opinion? Do you find much better when we use plasma light, especially the post-operative period and the anastomosis?
Could you repeat your question? I didn't.
Yeah. What is your opinion? Do you find it more useful while using the ringer lactate or plasma light in surgeries requiring anastomosis?
No, I don't. We are okay with either of them. And what happens is that if the surgery is going on for 7 to 8 hours, like practically now, we get a tray where there are 3 ringers and 3 plasma lights, 1 jello fusion and kind of things. So when you finished your 3 ringers, the next goes to plasma light, and then you ask for more fluid. So it's a kind of a combination of both. And if it's a liver resection or all, then I don't like to give ringer.
Okay.
Then it is plasma light.
Yeah. I think we can end this question. The questions keep on coming, and so we can. And Dr. Nevin, hello, Dr. Nevin. Please unmute.
Yeah. Can you hear me? Hello?
Yes.
Hello?
Yes.
Can you hear me?
Yes.
Hello?
Some disturbance. Nivin, you are muted. You are muted.
Yeah. Now I'm again. Hello? 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 Arun, please continue. Arun.
Yeah, okay.
Please continue.
Okay.
There's some problem with my audio.
So we will wind up the session. Thank you, Dr. Shalini Madam, for an excellent and elaborate talk on fluid, which was the most needed talk in the recent times. So on behalf of ISA Thrissur and all other participants, I express my sincere thanks to you. Thank you, Madam, for accepting our invitation to ISA Thrissur. We would like to hear more from you in future also.
Okay, sure. My pleasure. And
Yeah.
I wish to thank all of you, and it was very good interacting. And I hope the lecture was not too
No, it was an excellent.
boring and too long, but there were too many things to cover, and I'm still like there's too much of literature to
Yeah, and
but still it was very good.
yeah, and for the attention of participants, for receiving the e-certificate, you have to fill the link that is provided in the chat. Please apply through this for the participation certificate. And this talk will be uploaded in the YouTube channel of ISA Thrissur. So please subscribe to ISA Thrissur YouTube channel. It will be it will be uploaded with your permission, Madam.
Yeah. Sure.
Yeah. Yes, Madam. Okay, so it will be uploaded in the YouTube channel of ISA Thrissur, so that you can watch it again and clear your doubts. Okay, so we shall wind up the session. So on behalf of ISA Thrissur, I would like to thank Dr. Shalini Saxena and all other participants who joined to this session and made this session a successful one. And thanks to Soumya of MedPiper and JournoMed. Thank you for the support. Thank you all.